Hello, this is Dr. Nabih Mukhtar, and in this video we are going to talk about the target temperature management. Target temperature management refers to strict temperature control following the cardiac arrest, and this is actually through an active treatment that tries to achieve and maintain a specific body temperature in a person for a specific duration of time. And that's because the data from animal and human trials indicate that mild induced hypothermia is neuroprotective and improves the outcome after the cardiac arrest. And we can say that pulse 33 degrees as a target and 30. But following the TTM trial in 2013, we find that 36 degrees is becoming the preferred target temperature for post-cardiac arrest temperature control, and that's because of several reasons. The first is there is a reduced need for vasopressor, and we find that the lactate values are lower. However, we don't know the clinical significance of this. And number three is the rewarming phase, which is shorter. And the last reason that we find that there is a reduced risk of rebound hyperthermia after rewarming. So how does it work, or why it is neuroprotective? It actually works by decreasing the metabolic rate of the brain and subsequently the brain oxygen demand, and also by decreasing the release of the harmful molecules such as the free radicals that might damage the brain. So what are the indications for the target temperature management? We can say that patients who have the following criteria are eligible for target temperature management, but bear in mind that avoidance of pyrexia is paramount for all patients post-cardiac arrest. But these criteria are actually include patients who have less than 15 minutes between the collapse and the first attempt at resuscitation, and less than 60 minutes from collapse to return of a spontaneous circulation, and less than 6 hours from the ROSC. The patients should be comatose and requiring respiratory support and able to maintain systolic blood pressure more than 90 mm mercurial, even if vasopressors are required. Exclusion criteria include coagulopathy, but bear in mind that thrombolysis is not a contraindication, or if the patient has an established multiple organ failure with prolonged hypotension and hypoxia, and also in cases of severe sepsis. But also you need to know that these contraindications may not apply if the temperature target of 36 degrees is selected. And now you need to know that the target temperature management consists of three phases. The first phase is called the induction. So during this period, you aim to reduce the core body temperature to the target temperature, and then followed by the maintenance. So you need to maintain this target temperature to a period of 24 hours. And then you go through the rewarming phase, which is either controlled or passive rewarming to the normothermia, so 37 degrees. And you need to do this slowly, so ideally from a quarter degree to half degree per hour, and this could be over 6 to 12 hours. Bear in mind an important tip that there are some patients who are actually cooler than 33 degrees at the time of presentation post-ROSC, so these patients need to be actively rewarmed to the target temperature at a rate not more than half a degree per hour. So what are the methods for cooling during the induction and the maintenance phase? So we can use IV cold fluid infusion at 4 degrees, and this could be either Hartmann or normal saline as an IV boluses. But take care that stunned myocardium after ROSC may not tolerate aggressive volume loading, and the use of 250 ml IV boluses with clinical assessment is recommended. Other methods of cooling include ice packs, cooling vests, and let's talk about complications that could happen during the cooling process in the induction or the maintenance phase. First of all will be the bradycardia, which could be happen, but notice that the antimuscarinic medications might not be effective in cooled patients for treating severe bradycardia, and you might need to consider raising the target temperature, but it is very unlikely to happen if the target temperature is 36 degrees. Also, the second thing you need to know regarding electrolytes, you need to know that potassium, magnesium, phosphate move intracellular during hypothermia, causing lowering of the serum concentration. Also, the reverse is occurring during rewarming. And when you mention hypokalemia, so you might consider dysrhythmia that could happen. One of the other things which can occur in a cooled patient is low white blood cells or high PTT, and the also high liver function test. But all of these very unlikely to require treatment. The other things you need to know that cooling will lead to increase in the pH of the patient, which means more alkaline, and that's because the hemoglobin will accept more hydrogen ions during cooling. And finally, one of the most important complications you need to know is shivering, which can actually occur in post-cooling or rewarming phase. But during cooling, it will make the patient difficult to cool and can be managed by increasing the sedation or adding neuromuscular blockade. So what are the complications of rewarming? First of all will be the hypotension that might occur as the patient vasodilates, so intravenous fluids may be required. And as we mentioned, the potassium level is likely to rise. So bear in mind to stop any potassium infusions during rewarming. Also, shivering could happen during the rewarming phase, and that might lead to increased metabolic demand. So again, we can keep the patient sedated, and we can use neuromuscular block to stop the shivering. And finally, the patients with brain injury may become hyperthermic and may need to actively recool again. This phenomena is called rebound hyperthermia, and it is quite common in patients with brain injury. Thank you. Hope you enjoyed this video, and meet you in the next one.